Yes. Dr. Devang, you can switch on your video. Yes. So good morning, friends. Welcome back to Saturday Club meeting. And today we have a very young pediatric rheumatologist with us, Dr. Divynag Pandya, who is from Jamnagar, but now practicing in Ahmedabad. He's a pediatric rheumatologist and immunologist. And he had a long journey of rheumatology training and a lot of achievements to his credit. He got APLAR and PRES International Fellowship at Great Ormond Street Hospital for Children at London. He was there for 6 months. Then he had IAP Fellowship at Sir Gangaram Hospital, New Delhi for 2 years. ULAR certificate in pediatric rheumatology, musculoskeletal ultrasound, and nail fold capillaroscopy at Zurich and Denmark. And he also had a fellowship in autoinflammatory disease at National Amyloidosis Center, Royal Free Hospital, London. And to his credit, he has several international and national publications and also a speaker at international conferences. Altogether, he has 10 years of experience, and now he's settling in Ahmedabad to do his pediatric rheumatology practice. So today we are going to learn an overview of autoinflammatory diseases from Dr. Devang. Dr. Devang, welcome to Saturday Club. Thank you for being our guest speaker. Now you have about 40 minutes to talk, and we'll keep 10-15 minutes for interaction also. So over to you, Doctor.
Yeah. Thank you, sir, for a kind introduction. And I'll just share my screen now. Yeah, sir. Is the screen is visible?
Yes, yes.
Yeah. So good morning, everyone. So today's topic, as sir told, that it's an overview of autoinflammatory diseases. Now, and I have no conflict of interest, and photography is allowed during my presentation. So first we see that from where the word autoinflammation has arrived. So in 1949, there were symptoms of FMF, which is familial Mediterranean fever, which was called as a periodic fever by Professor Hobart. And followed by that, between 1990 to 1997, there was a gene invented for 3 autoinflammatory diseases, formerly known as periodic fever syndromes, that is FMF, TREPS, and hyper IgD syndrome that we see in the subsequent presentation. Up to now, we were like, there is always a reason for inflammation. Yeah, some infection, some injury, some malignancy, some autoimmune diseases. But in 1990, Professor Dan Kastner and team has thought that they don't think there is always a reason for inflammation. So sometimes without any insult, without any endogenous or exogenous threat to the body will produce an excessive inflammation, which is perfectly unprovoked. So say a common word for unprovoked inflammation is automatic inflammation. And so from this, the word came autoinflammation. So without any insult, there is a severe systemic inflammation in the body. So this is about the word autoinflammation. Now, to understand, we'll just have a look about some basic immune system function. As we know, the immune system is divided into the 2 parts. One is innate immunity, another is adaptive immunity. So this is actually not the types of immunity, because these both systems are integrated and bidirectional. So innate can send signals to adaptive, and adaptive can send signals to innate immunity. Now, what is the basic components of the innate? The physical or chemical barriers, complement system, many cells, and cytokines. So what this innate immune system do to our body? If there is an endogenous or exogenous threat, the most important thing is to recognize that threat. So the first contact with this threat is always an innate immunity. So innate immunity is very rapid and short lasting, but it is not specific. It is not antigen specific. Whatever threat is there, if it is a self or non-self, they'll just give alarm signals. And this innate immunity system is not regulated, and there is no memory. So what innate system do is just recognize and pass signals to the adaptive immune system, which is basically an antibodies and autoreactive T cells. Now, what is the role that whatever message came from innate immunity, if it is a self-antigens, adaptive immunity tolerate them, and because of this, there is a prevention of autoimmune diseases. And what other things will do if the threat message passed by innate immunity is some exogenous threat like infections or some disease or something, then adaptive immunity will reject, and if there is a pathogen, it will destruct that pathogen. So obviously it's a second response. After, if innate immune system sends signals, then only adaptive immune system works. So it's a slow, but it is very long lasting, and it is antigen specific, as we know, and it is fully regulated, and it has a memory. So the next time if attacks come, it will potentiate the immunological effects. Now this basic system we know. Why it is important to know before autoinflammation? Because autoinflammation is basically a disorder of innate immune system. Adaptive immune system has a very little role lately in the disease presentation. So now, generally, what happens if our immune system is not working properly? So there are 6 types of phenotypes which can happen. One is inborn errors of immunity, which is earlier known as primary immunodeficiencies. So we know some severe infections, unusual infections, and recurrent infection. What other phenotype? That is allergic diseases. What other things can happen if our immune system is not working is, as we have discussed, that if immune system is not able to tolerate our self-antigen, then it will produce antibodies to our own antigens, and which is autoimmune inflammatory and rheumatic disease, the base of the rheumatic diseases. And the patients can be prone to malignancy if there is immune system malformation. And today's our talk is autoinflammatory diseases. So that also comes under basically an immune system malfunction. And in that, it is a disorder of innate immunity. Now, how this concept has developed and what is the exact concept of autoinflammation at present? So first of all, it is to be continued because it's still a developing phase. But if there is a single gene responsible for such diseases, then it is known as monogenetic autoinflammatory disorder, which is the classical autoinflammatory diseases, and which is like our talk's main center of attraction. Now, if there is more than one gene involved, it is polygenetic. If it is more than genetics, like some environmental factors, infections, then it is multifactorial. And presentation many a times overlap with some unusual infections. Autoimmunity, so rheumatic disease, can overlap with autoinflammation, sometimes malignancy and other systemic disease as well. So after listening to this, feels like it's a complex interplay between the genetics, immune system, infections, and other environmental factors, and either it can present with autoinflammation, autoimmunity, or both. So still this concept is evolving. Now, if we see the basic pathogenesis, as we have discussed, the PAMP is pathogen associated molecular pattern. So basically it's a strangers, outside strangers, like infections or injury or anything. And what is DAMP? So DAMP is an inside endogenous threat. So it may be injury to some tissues, autoimmune diseases, or something like that. So our body ultimately has 2 types of threats. There's strangers and the dangers. Now, if one of this is present, what our body will do? So our body in the innate side have many cells and they have PRR. What is PRR? It's nothing but a simple small molecule which detect these either strangers or dangers. And after detecting, the cells will release a series of cytokines, and which we cause inflammation in our body. So this is a normal scenario. If there is a danger, either PAMP or DAMP, it will work on PRR, and there is a flow of different cytokines. Now, a simple pathogenic defect in the immune system, like how autoinflammation will develop. So this is our normal process. Inflammation should happen after each and every infection for the prevention of this infection. But here in autoinflammation, there is actually no danger. So without any danger, body will follow this process. And there is a tremendous amount of cytokines actually without any infection, without any reason. And this cytokine storm kind of picture will give rise to a clinical presentation of these diseases. Now, there are three pathways. I'll just tell the names. That NF-kB pathway, if gets activated, there is a release of TNF alpha cytokine. If inflammasome pathways get activated, there is a release of IL-1 cytokine. And if there is an interferon pathway activated, there is a release of interferon alpha. Why I have mentioned? Because this is very important for the therapeutic implications. And if this system has not been treated here, then it will affect adaptive immunity, and this whole scenario will become permanent, and patients will come at very late stage and some irreversible damage. So basically, innate immune system dysfunction will cause autoinflammation. If it does not get treated, then there is an involvement of adaptive system dysfunction, and there is a presence of autoimmunity lately in these diseases, and it will cause irreversible damage. So ultimately, these diseases are called rare, but they are not rare, and there is a tremendous amount of window period. If we treat here, it will not progress to involve adaptive immunity. Now, clinically, when to suspect, because there are many autoinflammatory disorder and still evolving. So if you have a child with presents to you with either recurrent or persistent, unexplained, this word is very important, unexplained inflammatory episodes, like these episodes are very mimetic, stereotypic, unprovoked febrile episodes. Every time, like similar duration, regular interval, and identical associated symptoms. And in between episodes, child usually remains very fine. And usually many of the disorder will not cause failure to thrive as well. So child looks perfectly normal in between the episodes. But yes, before labeling this clinically, we have to rule out common infections. Like if recurrent fever with cough cold, we know it's a recurrent respiratory tract infection, which is normal for some age group. So we have to exclude this, or some localized infection, or obviously any systemic infection, some unusual infection which is causing recurrent fever. Usually these episodes does not respond to routine antibiotics. And as we discussed, we have to exclude unusual infections and malignancy. This is an important clue that which type of febrile episode we should suspect autoinflammation. Now, what are the usual accompanied symptoms with the fever in autoinflammatory disease? Like rash, any kind of skin rash or skin lesion, serositis, there will be a pleural effusion, pericardial effusion, peritonitis, arthritis, or any musculoskeletal symptoms like arthralgia, myalgia, bone pain, uveitis, which is a red eye like intraocular inflammation, and mucosal ulcers, which is in like buccal mucosa as well, and the GI tract as well. So these are the usual associated symptoms. Now, this spectrum is expanding. So now this diseases, we know that they have a multi-organ spectrum. Like in central nervous system, it can present with recurrent meningitis and we don't find any cause. So I'll say aseptic meningitis, stroke, recurrent stroke, basal ganglia calcification. On cardiovascular side, it can present with systemic vasculitis, which is again a multi-organ disease. In respiratory system, it can cause interstitial lung disease. In GI tract, it can cause enterocolitis and myositis as well. So there is a multi-system presentation, but a typical febrile episodes with some common symptoms, and if more than one system is involved, this is how we should suspect autoinflammation. And what are the usual patient profile? Usually this child presents at young age of onset, like less than 5 years of age, and many 5 to 9 years of childhood age. But obviously there are many autoinflammatory disorder we know now in adolescent and adult as well. Consanguinity, it is very important history point, and family history. These two things is very important in the history point. If there is a consanguinity, family history, and you have a recurrent febrile episodes like we have discussed, we definitely need to suspect autoinflammation. Now, how the laboratory helps you here? So if you are suspecting already and child came during episode to you, almost always there should be elevation of acute phase reactants, which are usually used as CRP, ESR, and ferritin. Most of the time it is only during episode, but it does not mean because some severe autoinflammatory disorder in between the episode, child looks perfectly fine. But if you get blood reports, you can find still there is a CRP, ESR, and ferritin is raised. So as we have discussed, is a recurrent or persistent, but most of the cases only during episode ESR, CRP, and ferritin and all that usually get raised. Now, in any PUO cases, we sometimes send some autoantibodies to rule out or rule in some diseases. So like ANA, rheumatoid factor, anti-CCP, and ANCA antibodies. Usually, as we discussed, this is typically a disorder of innate immune system. So this antibody usually come negative in autoinflammatory diseases. But again, there are an overlap between the autoinflammation and autoimmunity. So if child presents late to you, or if there is a late diagnosis, in many of the autoinflammatory diseases now, you'll find high titer positive multiple antibody, that this child will have ANA positive, RF positive, anti-CCP, and ANCA that we see in subsequent slides. But most common, this antibody usually remain normal because this is the base of immunopathogenesis, and this is a clear-cut demarcation that rheumatic diseases, autoantibody, autoimmunity positive. Autoinflammation is basically an innate immune system, so autoantibody usually negative. And a simple CBC will help you because thrombocytosis is an important inflammatory marker other than ESR and CRP. Yeah, but in absence of severe anemia. And leukocytosis, but this is not much specific. All these investigation are not much specific, but it will just add to your clinical diagnosis. Now, what would be the possible steps if you are suspected, you find that ESR CRP is raised? Then either if you have a facility, then refer to some specialized center, or you can manage a fever diary, which you can tell patients that please note the fever pattern and the duration, because duration to differentiate this disorder is very much important. What are the accompanying symptoms? What are the inflammatory markers during and in between episodes? And mention if any therapeutic trial has been given, because which will also help sometime in the diagnosis retrospectively. Otherwise, we know that genetic diagnosis is mainstay, but all the time it is not possible. So sometimes we have to treat child on the clinical judgment and diagnosis. And sometimes if you are suspecting clinically and you don't find in genetics, you can give a targeted therapeutic trial. And to give this, our etiopathogenesis of TNF alpha, IL-1, cytokine, and these are all important. Now we start with the all disorder in brief. So the first group, which is like IL-1 cytokine mediated. So this IL-1 cytokine mediated, it is important because this all disorder works better to the IL blockade agents. This we'll see in subsequent slides. So if it is IL-1 mediated autoinflammatory diseases, it is known as inflammosomopathies. Now, in that, we know most common is FMF, earlier known as periodic fever, familial Mediterranean fever. What is the classical presentation? If you have some adolescent boy or girl and fever episode of very brief, like 1 to 3 days, and it will present with polyserositis. So what were the symptoms? Like chest pain, abdominal pain, some joint involvement, usually migratory polyarthritis, and this type of erysipeloid rash, and that is typically a site of FMF like dorsum of feet, you have to suspect clinically FMF. But obviously there should be a recurrent episodes, not a single episodes. And in this patients, if you do not have a facility, you can just give a simple medicine, colchicine trial. And if you have a dramatic response, it will retrospectively prove your diagnosis. Other is hyper IgD syndrome. The typical rash is maculopapular rash involving whole body with febrile episodes, early age, like less than 5 years of age. The typical episode lasts for 3 to 7 days, same arthralgia symptoms. And here the demarcation is loose stools. Loose stools is the most common feature of hyper IgD syndrome, and lymphadenopathy, which is usually painful and cervical lymphadenopathy. Now, here also, other than genetic test, if you have a clinical suspects, raise inflammatory markers, and if you found elevated IgD level, again, you can give a therapeutic trial. Now, this is a severe form of hyper IgD syndrome, which is MKD, which is obviously present in very early age, infancy age, with all sort of multi-system manifestation like failure to thrive, CNS manifestation. And in that also, other than genetic, you can measure a urine mevalonic acid. Now, other disorder in inflammosomopathy, this is also an IL-1 mediated, which is CAPS, which is cryopyrin associated periodic syndromes. It is divided into 3 parts according to the clinical severity. But the commonest of all is urticarial rash. So recurrent fever, urticarial rash, you are suspecting autoinflammation, think of CAPS. And if you biopsy this lesion, you should find neutrophilic dermatosis. This is also another than genetic help, genetic diagnosis help that you can get. And what are the manifestation? What are the other disease? Like 3 diseases under this CAPS. And the first is known as FCAS, which is familial cold autoinflammatory syndrome. It is present very early age. Fever lasts just like less than 24 hours. Joint symptoms, usually we cannot pronounce it this age. And always a cold exposure. Now, other is a little bit on higher age. Muckle-Wells syndrome, childhood or adolescent, 1 to 3 days of fever, again joint issues. And typical here finding is this child will have sensory neural hearing loss. And the most severe form, which is known as NOMID, and this is the picture why I have put, because if you have a such child with a globular swelling of the knee joint and you do not find any joint effusion, but instead of that, this effusion is due to patellar overgrowth, and patellar overgrowth is a marker of the CAPS severe spectrum, and which is NOMID, neonatal onset multisystem inflammatory disease. So it presents in infancy, failure to thrive, facial dysmorphism, persistent fever, organomegaly, cytopenias, and typical CNS involvement, which will be because of the chronic aseptic meningitis, macrocephaly because of the ventriculomegaly, basal ganglia calcification, which is an important marker of autoinflammatory disease, retinopathy, and again sensory neural hearing loss. This is the severest form, and this is like a spotter, because if you have seen, we'll never forget that this is NOMID. Now, other group of disorders, like if it is associated with TNF alpha cytokine, it is known as relopathies. And in that, main dominant disease is TRAPS, which is TNF receptor associated periodic syndrome. The similar presentation like FMF, but here you can see the febrile episode lasts more than 7 days, while in FMF, a short episode, 1, 2, 3. And here, there is a significant myalgia rather than joint involvement. Other all symptoms are similar to the FMF, and there is a migratory rash, and there is a significant muscle involvement as well. Now, this TNF associated means TNF blockade will help in the management of these diseases. Other disease is haploinsufficiency A20, which is nothing but a Behçet's disease. If Behçet's disease like presentation present at very early age, you should think of haploinsufficiency. So it's an early onset, same like a Behçet's, oral ulcers, genital ulcers, GI ulcers, arthralgia, eye involvement, and other vasculitic rash. So if you have a Behçet kind of picture and you feel the child is very young, you need to suspect HA20. And as we know, Blau syndrome, it is a similar like a sarcoidosis. So if you have a sarcoidosis like presentation at very early age, you need to think Blau syndrome. And what is the trad of Blau syndrome? The first picture is showing sago grain, very small raised papular kind of rash that is easily palpable like a grains. So that is known as sago grain rash. Then such kind of destructive polyarthritis. And this is a classical hallmark. If you have any child with a swelling which is juxta-articular to the wrist, and you have excluded rickets, vitamin D deficiency, and there is some eye involvement, you have to suspect Blau syndrome. So triad is Sjogren rash, this type of destructive polyarthritis, and this swelling is due to extensive tenosynovitis and granulomatous uveitis. So if you have this triad, you have to suspect Blau. Now other interferon alpha mediated, which is known as interferonopathy, and these features are common amongst all interferonopathy. Like if you have a skin vasculitis, basically on the tips of the fingers, like because of the exposure to the cold, like paniculitis or redness or vasculitic ulcers, gangrene, even up to auto amputations, you have to suspect interferonopathy. And interstitial lung disease, again, we can see basal ganglia calcification, myositis, and in this interferonopathy, it can raise liver enzymes due to secondary involvement. And this is the autoinflammatory disease. We'll find multiple autoantibody even comes positive, and it get confused with many rheumatological disorder. And in this also, in some centers, other than genetic analysis, we'll do interferon signature assay, which is again a genetic analysis, but it is more than NGS. Now in this SAVI, which is sting associated vasculopathy, you can see a severe gangrene over the tips, interstitial lung disease, vasculitic changes, and lupus-like rash. We can see it's a malar rash. So if you have an early onset lupus, like less than 5 years of age, always think that there is some genetic reasons for this lupus. Otherwise, lupus is common after 8 years in pediatric. and other features like, as we discussed, transaminitis and all. Other disease like AGS, it's also an interferonopathy, the same symptoms, but the difference is this child have a significant CNS involvement, like we see in primary organic brain disorder, like CP, stroke, and all the developmental delays. And this is a candle, same like a disease of Savi, but the differentiating is a violaceous eyelid and significant myositis. So this is actually mimic with juvenile dermatomyositis, because this child same presence with rash and muscle involvement, and it can confuse with this autoinflammatory disorder. So early onset JDM, think of candle as well. And the newest of the disease, a Copa syndrome, if you have a child with polyarthritis and you find on clinical examination clubbing, and if you get HRCT, you get ILD, we should not simply treat as a polyarthritis plus ILD, but we have to think of this new Copa syndrome. And only genetic analysis can confirm this, because the treatment is totally different, because interferonopathy works well to the JAK inhibitors than other any medications. And this child will have multiple autoantibody positive like RF, ACPA, ANA, ANCA. So this again confused with routine rheumatological disorder. And the last category, it's autoinflammatory bone disease, which is collectively known as non-bacterial osteitis. So which is like opposite to the osteomyelitis, because osteomyelitis is like an infectious bone involvement, but this is autoinflammatory, so inflammatory bone involvement. So which is known as NBO or CRMO, and there are multiple names. This is a typical presentation like childhood or adolescent. There is a localized bony pain and swelling, sometimes night pain as well. And the typical joint, if you have a clavicle involvement, it is almost confirmed that it's a CRMO. Most common other bones are metaphysis of the long bones, ribs, and vertebrae. So the axial involvement. And if this presentation, if it is present in less than 2 years, again, you have to get genetic analysis. And before jump to this non-bacterial osteomyelitis, we have to exclude unusual infection and malignancy. Now, if in less than 2 years CRMO, there is one syndrome known as Majid syndrome, which again present with recurrent fever, this type of CRMO picture, and the differentiating feature is a congenital dyserythropoietic anemia, so which can easily mimic thalassemia. And this child will have such generalized pustular rash as well. And another symptoms, these are all rare disorders, which is a deficiency of IL-1 and IL-23, which presents with the same symptoms like pustular rashes, this much globular swelling, and recurrent oral ulcer sometime, and pyoderma gangrenosum as well. And this present in infancy age. Now, miscellaneous, this is a famous disease. We know that Dada-2, this comes under miscellaneous, because this etiopathogenesis workup is like, it is not fitting into any categories. What is the commonest presentation of Dada-2? Recurrent fever with lividoid kind of rash. So purplish meshwork like of rash, typically over the lower limbs. And earlier, the disease was like polyarthritis nodosa, so abdominal pain, systemic vasculitis, lividoid rash, significant myalgia, and neuronal involvement sometime. And now we know that it can cause a bone marrow failure as well, so immunodeficiency as well. So this is an example of autoinflammation and immune deficiency as well. And here also we have a very good test. If you are suspecting Dada-2, you are not able to get genetic answers, get ADA2 enzyme activity. If it is severely disturbed, you can treat this patient with TNF blockade. And another such miscellaneous, and this is the last in our presentation, Papa syndrome, which is pyoderma gangrenosum, cystic acne, and pyogenic arthritis, usually monoarthritis, knee and elbow. And this child also responds to a different kind of biologics like maybe TNF and maybe IL-1, because still this disorder we are not able to categorize in any etiological pathway. So we have seen that rheumatology phenotype mimics, like we feel that this is a simple rheumatological diagnosis. Like you have a child with polyarthritis and you have RF antisensitive positive, so you are sure that you'll treat with methotrexate and all. But please remember, if you have such child and you find clubbing, you think of COPA, as we have discussed, and Papa syndrome can mimic with monoarthritis and pyoderma gangrenosum, which is again a common disease presentation of inflammatory bowel disease, which can mimic with Papa syndrome, and a systemic JI, which is like fever, rash, and polyarthritis, which can mimics with many of autoinflammation, like we see, because the commonest presentation of autoinflammation is fever, rash, and arthritis. And if you have a very deforming arthropathy in setting of GI, think of Blau and other disorder. And as we have discussed, if you have an extensive tenosynovitis, similar like rickets, bony overgrowth, think of Blau syndrome if you have excluded. And if you have a lupus or JDM like syndrome at very early age, we should not simply treat as a JDM and lupus, but if a less than 5 year, we have to rule out autoinflammatory disorder. And same like vasculitis at an early age, we need to think of interferonopathy and the other two. Now, what about the medication? So basically, when you are in clinical judgment, your diagnosis is pending, but still you are getting some raised inflammatory markers and you want to help your patients, you can give a simple ibuprofen during the episodes or naproxens or a short trial of glucocorticoids. But before giving this, we have to exclude infections and malignancies, that we are not missing this. And many of this disorder works well to colchicine, and colchicine had a multiple roles, like it had a diagnostic role as well, prophylactic role, like some disease will give colchicine for the prevention of the attacks, so prophylactic, and sometimes only colchicine will help and we need not to go towards the biological agents. So diagnostic, prophylactic, and therapeutic. Like if we ask a rheumatologist, the father drug is like methotrexate, and if we ask an autoinflammatory specialist, a colchicine is like a father drug. And what is the medications available in India? The IL blockade, because as we see, many disorders are IL-1 associated, which will respond to IL blockade like anakinra and canakinumab, which is officially not available in India. But for some of the patients, we can able to get this medication from the Middle East countries or from the Western countries, if at all it is required, and if the role is like to prevent damage. TNF blockade, which is freely available, like etanercept, infliximab, and adalimumab. So all TNF associated disorder we can completely treat here. And JAK inhibitors is also available in India in the form of tofacitinib and baricitinib. And these drugs works well in interferonopathy. So out of the 4 major categories, we have drugs for 3 categories, because autoinflammatory bone disorder also works well to the IL-1 blockade, sometimes TNF blockade. And tocilizumab is available, but is rarely used in some autoinflammatory disease. So only IL-1 blockade is not available for management point of view. Other all disorder we can treat the patient very effectively. Now, after treating, don't forget why we are so much worried about this autoinflammatory disease, because it's like a recurrent episodes and in between child is fine, but there is a risk of amyloidosis if there is a persistent inflammation in the body. If there is a non-clinical inflammation also, like without any symptoms, but persistent raised of ESR and CRP, there is a risk of amyloidosis. So if you have a child with recurrent fever episodes you are not giving any medication, you feel this child looks like a normal in between episodes, so I'll wait and watch. But if you found that in between episode ESR and CRP remains persistently high, and if there is a progressive hepatomegaly or splenomegaly, progressive worsening proteinuria, so urine examination is very important, progressing worsening renal function, and if you have a facility for serum amyloid A level, and if there is a persistent elevation in between the episode, you think towards amyloidosis. Amyloidosis will take years to develop, but we have to, we don't want to develop amyloidosis, we have to prevent amyloidosis. So this is important to know. And how we usually monitor this patient, that after starting a treatment, this child will have dramatic response, parents will get satisfied like a cloud nine. But the difficult part is a follow-up, a monitoring. So episode diary they have to maintain. Any new symptoms or sign which suggest actually disease progression or widening spectrum. And there are a typical autoinflammatory disease activity and disease damage scores that we usually use in our OPD practice, and physical and quality of life scores, which is a common like other disorders. And each and every visit, like every 3 months follow-up, we see CRP, ESR, ferritin, and serum amyloid A, and urine routine and urine protein estimation, liver kidney functions. This is for like if this child are on medications, so for that routinely we see lipid profile, typically for the JAK inhibitors. And obviously before starting any biologic, we have to get done pre-biologic workup, which is like CBC, routine, or SGOT, SGPT, and TB screening, like chest X-ray, TBQ gold, or Monto's text, or and if some of one comes positive, we can go for an HRCT as well. We should keep low threshold for such investigation before starting biologics. And if each child is on biologics, we have to screen tuberculosis every 1 to 3 years, depending on the situation. So this is how we have to monitor. And some will think that the most common PFAPA autoinflammatory syndrome is not covered, because this is actually a most common autoinflammatory syndrome, which is PFAPA. PFAPA is periodic fever, aphthous stomatitis, pharyngitis, and adenopathy. This is the most common presentation, but this is not a monogenetic disease. If you get genetic test will not help much, because there are multiple reasons for this autoinflammatory disorder. So this is not a classical monogenetic autoinflammatory disease, but which is most common. So we'll see that usually less than 6 years of child, episodes like 2 to 7 days, at least 5 episodes before diagnosis, and maximum gap between 2 episodes, 2 months, in between again child normal growth. And this presents same like an infectious tonsillitis or pharyngitis. And we need to again exclude infections, some inborn errors of immunity, and cyclic neutropenia. This is very important. We can find in CBC, because cyclic neutropenia presents with the same mucosal symptoms. And in this child, if you are sure that this is an PFAPA, you can just give a single dose of oral prednisolone in the dose of 0.5 to 1 mg per kg per day, only single dose, and this child will show dramatic response. And sometimes we have to give for 1 to 3 days as well. And if it is very severe and cumbersome, very large tonsillitis and all that, tonsillectomy will help in many cases. And this is like a spontaneously resolving, so we are not much worried. This will not cause any permanent or irreversible damage. And as we have a many adult audience, so recently diagnosed autoinflammatory syndrome in adult, which is a VAXUS. V stands for vacuoles, which we find vacuolated precursor cells in the bone marrow. E stands for the even enzyme, which is actually because of the mutation. X stands for X-linked, because this is more common in males. A for autoinflammatory, the phenotype is autoinflammation, because there is a severe inflammation which is responds only to steroids, and there are some somatic mutations as well. And what is the commonest presentation? Skin rash, like we see in the sweet syndrome, periorbital angioedema, relapsing polychondritis, like we can see here in the ears, we can see kind of redness, severely painful and tender lesions, redness of eyes because of uveitis and scleritis, and a polyarthritis nodosa kind of picture like livedoid rash, systemic vasculitis, even lung involvement. And the typical hematological finding is macrocytic anemia, thrombocytopenia, and this patient predisposed to myeloid proliferative and myeloid dyserythropoietic syndromes. So like this can progress to malignancy. So this is an example, like autoinflammatory overlaps with malignancy and relapsing polychondritis, polyarthritis, so rheumatic diseases. So again, it's an example in the adult. And now there are a lots of paper after COVID-19 that COVID-19 is working as a triggering factor for many autoimmune diseases and many autoinflammatory diseases. In many of the conferences, we are seeing, and not in only this specialty, with other specialty autoimmune diseases like in central nervous system also, we are finding more cases of GBS and multiple sclerosis and lupus and JDM and this autoinflammatory disease as well. So there is a complex mechanism between the COVID-19, and some reports are there that after COVID-19 vaccine, some has developed autoimmune or autoinflammatory disease, but this is just a coincidence. It is not scientifically proven. And this is COVID-19 and autoinflammatory and autoimmune disease trigger. It's just a temporal association. There is no any strong scientific evidence. And this is for you, those who are not getting bored of this lecture, that there are many disorder and easy to remember charts you can find at this link. And this is a Nomid Alliance link. And this chart is very, very much useful because they have a clinical picture and they have a clinical a commonest clinical presentation for each and every autoinflammatory disease, which is actually I'm not able to show clearly in the slides, but this is the link that you can find this chart. And the last acknowledgements, because I learned autoinflammation from Professor Paul Brogan, Professor Despina, Dr. Muthana Al-Obedi, and I was fortunate because of the Satish sir and Dr. Raju Khubchandani that we have learned this autoinflammation in our rheumatology online series under the guidance of Professor Dan Kashner himself and Ivona Askenjevich, who are key figures in the autoinflammation. And other colleagues where I have done autoinflammation training, like Professor Helen Lackman and Harris Papadopoulou, and I was able to do the fellowship because of a European Association help. So I want to acknowledge them also, to Professor Angelo Ravelli and Professor Fabrizio and Professor Cesar Ozon. And thank you very much. So we feel as a rheumatologist is final destination kind of thing, and for you, like unexplained, unusual, unsolved, and unexplored. Thank you very much.
Thank you, Dr. Devang. You may switch off screen sharing.
Yes, sir.
Yeah. I think still you are shared.
Yes, sir.
Anyway,
No.
so
Is it still visible, sir?
yeah, no. Now it's all.
Okay.
Thank you very much, Dr. Devang. It was a wonderful overview of. I mean, you have opened up our eyes to a new set of autoinflammatory diseases, we as pediatricians are usually scared of rheumatology subjects, and it is supposed to be something which is with only those who are very passionate about it, because the complexities are more. But you have given a good overview of what these AITs are. I have one or two questions, and then we will keep it open for all others to debate.
Yes.
My question is regarding the kind of cases that you have shown. Until now, we have not heard much about them. Are they
Yes.
all cases you have seen during your training abroad, or you are seeing such cases in our country also? What is the epidemiology in our country of AIs?
Yes, sir. So basically, out of this that we have discussed, almost many cases I have seen in India, and almost all cases in Western world. But I must say, because there are some cases which is due to an environmental factor of cold, like interferonopathy and all, which are very more common in the Western world, that we are not finding here. Like I have shown the pictures of gangrene and auto amputation and all that. So these are not much common. But yes, the other disorder, which is like IL-1 mediated diseases, that we have seen a few of cases. I will not say many cases, a few cases I have seen, and the COPA syndrome and all that, few cases I have seen. But if we consider India as a whole, there are many centers in the Mumbai and in the Chennai and Lucknow. They have presented the data that in yearly they usually see a 50 new cases of autoinflammatory disease, and they have a bulk of like 500 patients to each center. So almost we can say like 5,000 to 10,000 diagnosed genetically proven cases. But this is, I feel, just a tip of iceberg. And as we have said that if lupus present in less than 5 years of age, autoinflammation comes under pictures other than complement deficiency. So this is actually, there may be many patients, but they are just waiting for their a perfect diagnosis, as I
Waiting
feel.
for them to see Dr. Devang Pandya.
No, not sir.
Thank you very much, Devan. We have Dr. Nitin Saha with us. Welcome, Nitin.
Yes, sir.
He
Hello, sir.
is a pediatric hemato-oncologist. So
Yes.
I'm sure he has some comments to make. Yes, Dr. Nitin.
Yes.
No, so I think I have attended a few lectures on autoinflammatory syndromes in the past. I had heard professor from PGH and they are showing Indian cases. So that's the answer to Satish's question as to how far it is common. Maybe the spectrum is different. Like for even primary immunodeficiency, we see that Westerners say that the 50% of their PIDs are hypogammaglobulinemia, whereas we don't see that here. It's less than 20%. But I think what Devang presented is an absolutely mesmerizing and simplistic way of approaching to an autoinflammatory disorder. I think we need to get sensitized to this subject. Of course, they are rare, so they are not going to be easy for maybe a very busy pediatrician like Satush may see one or two cases in his lifetime. But referral centers will always get such cases from all over. So, like we have the immunology department at Wadia, which is managed by now Mukesh, which is originally part of hemato-oncology. And they have also, at least, if I'm not mistaken, 25 cases of autoinflammatory disorders of variety that Devang showed. So, yes, it exists. It's only that your eyes will only see what your mind knows. The only problem is the therapeutics, because they're so expensive and not easily available, and many of them are lifelong. And unfortunately, many of them cannot be subjected to transplant, unlike malignancy or some PIDs. So that is the problem with compliance and overall outcome of these patients. It's very exciting to diagnose one, but it's very depressing when it comes to treating that patient. Am I
Correct.
correct, Deva?
Correct, sir.
Thank you.
So,
Dr. Nitin.
where is IgD level available? Because as I know, the last we were really struggling to get an IgD level for a suspected IgD disease spectrum.
Actually, sir, about the commercial level, I'm not aware still, but we usually get during the fellowship. I have seen 2 cases, and at Delhi, actually, in our lab, we are getting it done. Actually, Gangaram Hospital.
Great.
So about the commercial lab, I'm not aware, sir.
And last question, most of the cases that you showed are monogenic in inheritance, right?
Yeah.
So probably an NGS would pick up almost 80% of them.
80%, actually less than that, because sometimes there is always, as we know, that phenotype, genotype variation would be there, because sometimes we feel there is a classical phenotype and we don't get genotype. So around 60% will get the answer actually, because there are
Okay, and
many cases. Yeah. Yes.
yeah, sorry, go ahead.
Because there are many classical cases we also have, but we don't have a genetic proof, sir.
Okay, so my last question is that while you have done your fellowship abroad and you have worked here at Gangaram and other centers, of the autoinflammatory disorders that you saw and you send a genetic test, as far as different parts of the world is concerned, are there any new mutation of the same syndrome? Like, because we have seen, like, if you talk of HLH or you talk of some other genetic disorder, many times we have VUS on NGS, but we know phenotype is very typical, and that gene is involved in that particular disease. But just because that mutation is not there in the master bank, they won't say it's a
Correct,
significant
sir.
mutation. So we may be actually adding to the world's bank of mutation, and the country that we
Yes.
are such large, I'm sure it won't be surprised that there are, for the same gene known mutation, there will be lots unknown mutation which will be
Yes.
added only if someone applies the mind. So I mean, after this NGS labs, that there are 4 or 5 of them, just like MedGenome or something else, that they should all have a meeting together once in a while with clinicians and see which are really typical phenotype, which are matching with that particular gene involvement. And some mutations are seen in 4, 5 centers. Then we must say that they are added to the bank so that they are then reported not as VUS but actually
Yes, sir.
a variant of significance.
Correct, sir. Correct, sir.
Thank
Because
you.
the genes are single gene also, we are having multiple phenotype, and for multiple phenotype, we have a common gene. So there is also adding to the confusion actually.
Yes, we have Dr. Jagdish Chinappa from Bangalore. Yes, Jagdish.
Thank you, Dr. Devang. That was a fascinating lecture, and you had started off with the basic immunology and progressed. Just a few comments. We had an international conference on the autoinflammatory disorders at Bangalore with Dr. Anand being the organizing secretary, and we had a large number of speakers who came from Europe who gave a fascinating viewpoint, and you had simplified it very nicely today. I have only one question for you. See, this autoinflammatory disorders start off. How do they stop? What inhibits the inflammatory response?
Sir, actually, as we have seen that most of the autoinflammatory disease, we are able to point out that which is a specific cytokines which is responsible for all the subsequent cascade. So if we block that cytokine, it is just a break in that circuit and the inflammation will come down. But again, if you ask me that how to sustain it, so the therapy is ideally an open-ended therapy, but we sort of like making some shortcuts, like because of the financial and all that if child is stable on continuous 3 months cytokine blockade, then we start dropping. But this is just a break in the circuit, and sometimes we don't find any response as well with the same cytokine blockade. So still this field is evolving, but as far as the few cases which I have seen, usually if we start the specific medication, child clinically and lab wise, we are getting dramatic result. And basically to start, these medications will help preventing the irreversible damage. So that is, I think, more important, and give good quality of life.
Thank you. My question was, in a self-limiting autoinflammatory disease, like for example, PAFA, you have a child who gets this recurrently. What stops the inflammation? How does this child just recover, in a short period of time, and the inflammation stops?
Okay, for PFAPA, actually, nobody knows, sir, because PFAPA is like with the age, it will regress and it will stop on its own. But again, a PFAPA is not a predominant, a signature disease for the classic autoinflammation, because this is multifactorial. So we don't have answers for that, sir.
Okay, thank
Would
you.
there be some triggers, Dr. Devang, as you said, COVID-19,
Yes,
was
sir.
a trigger for some of these autoinflammatory diseases? Are there any researches going on to find out the triggers? Like, say, we see that in many cases, like say asthma, we always talk about triggers. So are there any triggers for AID?
Actually, sir, the COVID-19 was like a celebrity virus. So there are many case reports and everything was there. And from the all centers, like we know that PIMS and PIMS came in the picture. But still, for a PIMS and all this disease, a pilot project is going on. But they have mentioned it's just a temporal association. They are not able to find anything. And about this data also, there is no any, but yeah, each and every center is sending data, and there are many data that after COVID, these diseases are becoming more common. Or maybe COVID has created a great awareness about the inflammation and biologics and all. So maybe. I don't know, sir, actually.
As you said, it is an evolving specialty. So
Yeah, evolving. Yeah.
learning. Good. Any other question or comment?
Yeah, I just want to make one comment, Satish. That COVID virus and especially vaccines against COVID have been so abused. Now that the disease is gone, I see a very similar between polio and oral polio vaccine. That oral polio vaccine actually helped the world to almost eliminate polio. And now that the polio is gone, everyone thinks OPV is a demon. I think the same is for the COVID vaccine. When the vaccine was not available, people were queuing up. Okay, when they are all okay, now the vaccine is, the disease is gone. Everything which has happened during COVID time is blamed. Someone developed myocardial infarct is because of COVID vaccine. Someone developed some thrombosis is because of the COVID vaccine. And as a community, we're a bunker community where we are not like respectful to something which has helped save our lives. I mean, that's my
find out
general comment. Yes.
Thank you, Nitin. Thank you. So thank you all. Thank you, Dr. Devang, once again. It was really very wonderful and a very simplistic way in which you have put this complex entity. So thank you very much. We look forward to more such talks in future related to your specialty. And thank you for joining. We meet next Saturday again. And that is also going to be very, very interesting. We'll have Dr. Vivek Jain, who is a dermatologist, who will be talking about gender dysphoria and other issues related to LGBTQ. So again, a very interesting topic upcoming in the next Saturday meeting. So thank you all. Join again.
Thank you. Thank you.